Good evening, good afternoon, and good morning, everyone. My name is Megan Kearns, and I'm a Senior Technical Advisor for HIV and AIDS at Management Sciences for Health. I want to thank you all for joining us for our session today, Reaching the First 90, a webinar on index case testing for HIV. During today's webinar, we'll be sharing examples from our experience implementing index case testing on projects in Angola, Ethiopia, and Malawi. Each presentation will be about 10 minutes long. We will hear from the Community HIV Care and Treatment Project in Ethiopia, from the Health for All Project in Angola, and from the District Health System Strengthening and Quality Improvement for Service Delivery Project in Malawi. The three presentations are pre-recorded, and we will run through all of them before we move to the live question and answer session with our presenters and with other MSH and partner staff. Throughout the presentation today, we'll be collecting questions through the web chat feature. To submit a written question, select Q&A on the right side of your screen and type your question into the box at any time during the presentations, and we will address it as possible during the question and answer session. So without further delay, let's begin our presentations.
Thank you for having me on this webinar. As you can see, my name is Asayeheng, and I am a Deputy Chief of Party for USAID Community HIV Care and Treatment activity, which is implemented in Ethiopia through the collaboration of MSH, PSI, and the Prime Project HOPE. I'll start with the problem statement. As you might have known, Ethiopia has a mixed HIV epidemic with an adult HIV prevalence rate of 0.9% according to the Ethiopian Demographic Health Survey of 2016, with high variability among different regions, genders, and by residents. As you can see, the prevalence in women is twice as high as with men, and we've also seen a significant reduction in new infections in Ethiopia. When you see the trend in HIV prevalence, it's getting lower in both sexes. Yet, we have seen slow progress toward achievement of UNAIDS 1990 goals, with only 78.7% of positives knowing their status. We've completed a population-based HIV impact assessment survey, which is FIA, in May, and we're awaiting the results to see how we're doing along this line. Even though we have this level of low detection of new positives in Ethiopia, there are some project reports that have shown that most of the clients for index-based testing would prefer community-based testing as opposed to facility-based testing, despite their limited availability. So I'll share the approach that we're following in this project. It's a new project that was awarded to Project HOPE in July 2017, and a service delivery has just been initiated in December. But there is an overarching campaign or catch-up campaign that FMOH launched in 2016 that identified modality and priority target groups for testing in Ethiopia in order to achieve the first 90. In this project, as part of the catch-up campaign, we provide index-based testing in the context of delivering comprehensive and high-impact HIV prevention, care, and support services at the community level. With local implementing partners working with the consortium, including NGOs, PLHIV associations, and their regional networks as service providers. These partners have brought on board health professionals who we call community engagement facilitators or CEFs, who are trained on the provider-initiated testing and counseling services, and they will provide index case testing at the community level under this project. The delivery sites for community-based index case testing in CHCT include homes of the clients, local implementing partners offices, associations offices, and other CBOs. When we come to the service delivery model we follow in ZHCT, we follow the hub and spoke model for delivering services in each subnational unit. We have high volumetrity sites as hubs from which our community engagement facilitators get the list of individuals that should receive index-based testing in the catchment spokes. In the spokes, these CEFs provide index-based testing and care and support services to the clients through various community-based volunteers and workers who work towards convincing these individuals to get tested in terms of index-based testing. So when it comes to the actual implementation, the approach of community-based index-based testing was in implementing this project after we developed various standard operating procedures, guidelines, tools, and job aids. And after we deliver various trainings to program staff, including CEFs. We also develop quality assurance standards and checklists that include routine data quality assurance tools. We also do bi-weekly review of performance data from sites, WRRs, and LIPs. In terms of challenge, we faced various challenges in the implementation so far, which include supply issues, and this is mainly kits were in short supply in some sites. We also had some problem in some of the waredas where we couldn't access index case client list from health facilities because of conflicting projects that work from the facility side. Similarly on index case testing. There also was the testing of family members and children without doing risk scoring, which is something that we faced at the beginning of the project, which reduced our positivity rates, and this was mainly in organizations that had similar kind of experience doing HTA services before this project. There was a high non-disclosure rate that affected uptake of community-based index testing too. And we also faced general stigma and discrimination of the community that affected uptake of index testing, so we had to struggle and try hard to our volunteers to convince people to accept their status. In terms of results of this intervention in the last 5 months, and our data shows that from the different charts that are presented, we've covered some 160 subnational units so far in this period, and we deployed some 297 community engagement facilitators. We've provided HIV testing services to 17,000 clients, of which 11,000, or the majority, were through index case testing. And our positivity rates were 3.8%. 95.5% of these new positives that we have identified have been linked to ART thus far. As you can see from the figures, the positivity rate in this project is increasing month by month because of the application of stricter risk assessment tools and for testing the beneficiaries. If you look at the graph at the lower right, you can see the different age categories to see where the higher and lower positivity rates are, and 5% positivity, as you can see, is observed in the age group 25 to 49. There is also variability among genders that we have seen in this project. In terms of actually moving towards self-testing in ICT, we got approval to incorporate self-testing in the context of index testing at the community level for the coming COP year, and in Ethiopia this approach has been tested for female commercial sex workers in another project run by Population Services International Ethiopia through their Mulu HIV/AIDS project. That self-test was done using OraQuick. This was not literally a self-test in terms of implementation because there was accompanying health workers who were there during the sex workers self-test, and this was per the request of the Federal Minister of Health. That approach, as you can see, has shown a yield of more than 5%, and the uptake was also not very small. It was more than 1,400 people tested, and all of those who self-tested positive were confirmed positive and linked to ART status, and this number overall has increased to more than 3,000 as we speak. So as ACT moves towards self-testing, we will be doing preparatory work at the national level to design necessary toolkits and get necessary approval and design. We avail the kits to be able to implement this in the coming year. When we go to the lessons learned so far through implementing community-based ICT, we have started to demonstrate the potential of community-based testing to detect a high number of new positives. The yield that we have observed in this project is also encouraging. It is very high compared to 1.1% yield reported in the catch-up campaign, and also that of 0.6% in routine service delivery. We've also seen the need to strengthen coordination and collaboration platforms for better communication between health facilities and to improve access to data and test kits in various service delivery outlets. We've also implemented risk scoring tools for children and family members and research thresholds for yield, which were key to improving positivity rates as you can see from the different month-by-month trend analysis. In terms of the follow-up and use of data for decision makings, we did support supervision visits, site improvements, and monitoring visits were also to service delivery points. Were also important exercises that we implemented in this project that helped us improve yield and detection of new positives. We've also set up a system to avoid table documentation of linkage reports to ART, which included employing positive tracking tools and different mechanisms from escorting clients to the facility to providing follow-up home visits to those who didn't start ARTs. The last two are the next steps we are going to take, not the lessons actually, to further improve our community-based index testing. One is to start partner notification services that we were awaiting approval from the Federal Ministry of Health for, and we got approval just recently, and we're also exploring self-testing for ICT, and that will potentially be scaled up in year 2. Thank you for listening, and I will welcome if you have any questions. Thank you.
Hi, my name is Thiago Costa. I am a Senior Technical Advisor. I'm working in the Index Case Test and Tracing on Health for our project in Angola. I will present the index case testing and how we are doing it in Angola. In this slide, we can see the results of many indicators of the project from October 2017 to March 2018. 3 of 4 indicators we have a good performance. These are patient testing with 80%, positive case with 56%, and treatment current with 90%. However, for the new treatment indicator, we had achieved only 25% of the annual target. Another point to highlight is that only 55 of the TB HIV co-infected patients have started ART. That is why we are focused on the expansion of the index case testing and tracing in Angola. What is our approach? Right now, index case strategy, we have only HIV target, but we will go expanding into the TB service. To do it, we have a team in each health facility. This team is composed by case managers, PAFs. PAFs means patient assistant facilitators, and community counselors. The case manager are doctors and coordinate all the team in the health facility. The PAF is a person living with HIV and AIDS. They are working on the counseling pre- and post-testing for HIV, and then the linkage to care. The community counselors, they are the principal actors of the index case strategy in the health facility. They do the index case. All of them have a permanent supervisor of each activity in the field by a senior staff. This approach shows the considerable success of our activity within in the field. We started this approach in June 2017 in 3 health facilities, and in February 2018 we expanded to another 3. The implementation was under the leadership of the Health for All project and INLS, the Angola's National AIDS Institute. What was our first step? We advocated and presented the index case strategy to directors of the health facility to receive approval for implementation. After this, we updated the training, and then the INLS and us trained 10 community counselors. These community counselors are teachers and other peoples of the community. Is not a people living with HIV. How we do the index case in the field? This diagram shows the steps from the first diagnosis to linkage of a positive contact. We always start with testing the patient in the health facility, and the test is done by nurse or PAF. Once a positive case is identified, the PAF introduces the new case to the community counselors. The community counselors explain the advantage to test the sexual contacts, marital and extramarital, and their children. After receiving the contacts of the patient and authorization, they will schedule a date and time for a home visit. To avoid stigma and discrimination, the counselors visit the homes of neighbors to talk about malaria, TB, HIV, and basic sanitation. But the focus is on the home of the positive case. Once in the house of the positive case, the community counselors make the HIV counseling testing. If there is a new positive result, they link them to care and treatment in the health facility. And there is a new positive case, and a new process began in the health facility. Now, I will show you the principal result of the index case strategy. We can see the result of the index case test and tracing in the 6 sites supported by the Health for All project. The red dots are the percentage of the positive tests. At the pediatric hospital, 80% of the contact tested were HIV positive. This is because the contacts are parents of the children and have a higher probability of a positive result. The green dots show the percentage of linkage to care. As can be noted, we have a good rate of the linkage to care. The lowest rate is in Divina Hospital because they are required to pay some laboratory testing and so that the patient has access to the first appointment. Overall, we have an excellent rate of positive tests, 29%, and linkage to care, 80%. The patients linked to the treatment through the index case testing represent about 20% of the new treatment. Now, we are showing you another important point, the difference between the positive rate achieved through index case strategy compared to regular HIV counseling and testing. The red bars show the positive rate in the index case, and the green bar show the positive rate in the regular HIV counseling and testing. As you see, the dispensario presents a minimal difference between the strategies. This is because the health facility is dedicated to care for TB patients, and patients with TB have a higher positivity rate than the general population. As you see, there is a big difference between the index case and the regular HIV counseling testing. This shows the effectiveness of the index case strategy. The great lesson is, through this project, we have found that index case strategy will help us to achieve the 90-90-90 target through testing, positive case found, linkage to treatment, and viral load suppression. Our slogan is Tracing HIV Contacts and Saving Lives. Thank you for your attention.
Hello, I'm Dr. Aziz Abdallah, the Project Director for District Health System Strengthening and Quality Improvement for Service Delivery Project, the DHSS. The DHSS project, funded by PEPFAR through the U.S. Centers for Disease Control and Prevention and led by Management Sciences for Health, was implemented in 7 districts in Malawi since 2012. The DHSS project aimed at improving the quality of, access to, and coverage of priority HIV-related health services. Among the services supported was HIV testing, where a number of approaches were implemented. Today we shall hear about one of the promising HIV testing approaches that was implemented. Please join me in welcoming Ms. Rose Miranda, the Director of HIV and AIDS Department at the Malawi Ministry of Health, for a discussion on index case testing.
Malawi has made great progress towards achieving epidemic control. However, achieving the first 90 target remains a challenge. According to our most recent Malawi Population HIV/AIDS survey in 2016, our progress towards the 90-90 targets was at 73, 89, and 91. Those results show that as more people know their HIV status, it is increasingly difficult to identify the remaining people who do not know their status. It also shows strategies that worked well previously or 15 years ago are now less efficient. So index case testing approaches are promising for efficiently and safely identifying HIV-infected persons. Index case testing was introduced in June 2016 and was implemented in 90 facilities in Malawi. It focuses on the spouse, sexual partners, and children of HIV-infected adults, as well as siblings of the HIV-infected children who are accessing services at a facility. We've been using family referral slips, and this index case testing was also provided family testing days, which were established on a weekend to maximize access. But also these services were being offered during the weekdays. As I mentioned, implementation started in 90 facilities, and we developed standard operating procedures. Staff were oriented to index case testing approach itself, but they were also oriented on use of family referral slips. And each slip was given to an index case, but also a sexual partner. The ministry also introduced registers for HIV testing, which have been used for all HIV testing services, but also reporting tools. So the standard tools that were established are the ones that were being used. And all facilities were oriented, focusing on 1,000 health workers. A special cadre of paraprofessionals, health workers, dedicated to HIV testing services, known as HIV diagnostic assistants, were recruited and deployed, and we recruited a total of 190. But expert clients were also used to support the patients and encourage the patients to bring their family members and also sexual partners. We also provided continuous mentorship to support case identification, documentation, and report generation. The results of our implementation showed that there was high positive yield in men that were tested, but also we saw a high positive yield among children and adolescents. And interestingly, the high positivity rate was much higher through index case testing at 22% compared to the national average yield, which is 4%. This approach demonstrated that it is an approach that would get high positivity compared to the other testing modalities such as provider-initiated testing and counseling, testing in prisons, but also even community outreach. There are some lessons that we have learned through the implementation of this approach in the 1-year period of implementation. Scaling up index case testing can fast-track progress towards achieving the first 90 target in Malawi as we move towards epidemic control. But also index case testing with family testing days showed a high diagnostic yield among all age groups. It was successful in reaching males and youths. 27% of those tested were children compared to routine testing, where this number ranged from 7% in 2012 to 16% in 2017. With the high HIV positivity rates obtained through this passive referral approach, it is worth considering more active partner notification approaches. Thank you.
Great. Thank you all for the presentations. If you'd like to view any of these presentations again later, we will be sharing a link to them via email following the event. So now we're going to get started with the live question and answer session. And joining us today are all of our presenters. We have Asayahen Tekese from the CHCT project in Ethiopia, Tiago Costa and Arturo Silva from the HFA project in Angola, and Aziz Abdallah from the DHSS project in Malawi, as well as Rose Nirenda from the Malawi Ministry of Health. We are delighted that all of them are available for our discussion today. And I want to thank all the participants that have already commented and sent questions. And please remember, you can submit your questions directly through the web chat feature, or you can also raise your hand on the screen to ask a question. To raise your hand, you click the hand icon in the bottom right corner of the screen. So let us begin with the first question. Delivering HIV testing services at the community level is different from conducting testing in a facility where there are different controls and systems in place. So I want to give each of you a chance to ask, to tell us about how you ensure the quality of your community-based index case testing service delivery. And I will start with Asayahen on that for this question.
Thank you, Megan. Yes, I hope can you hear us? Hello?
I can hear you.
Good. Thank you for raising the question. This is an important question. As mentioned, having this scale in implementing community-based index case testing program, quality is definitely going to be an issue. So by design, we have instituted quality assurance and improvement systems into the project, designing various quality assurance and improvement guidelines, minimum standards for service quality that are in line with the Federal Ministry of Health standards and that are based on evidence-based best practices we have in country. We have put in place various mechanisms to ensure proper training and proficiency testing for service providers who are community engagement facilitators who are certified. We also conduct various performance reviews at site level to check quality, acceptability, and friendliness of services. We also have quality improvement teams at various levels, particularly at the site level, where service providers, program staff, and the community level volunteers who are PLHIV peer support providers or peer facilitators who get feedback from the clients directly and who work jointly to address any quality related gaps that they have observed. So we have, as a new project, started cascading all these activities, and we're seeing consistent improvements in service quality so far. Thank you.
Thank you very much, Sayahen. Rose or Aziz, do you want to talk a little bit about how you ensure quality in the Malawi example?
Aziz, do you want to take up the question?
Okay. Yes, basically for the Malawi project, we were mostly implementing facility-based index case testing, and of course, quality, of course, is always very important. Now, in this project, we have Ministry of Health, the Department of HIV and AIDS has HIV testing services quality standards that we have to adhere to. So one of the things that we made sure to ensure that the quality is adhered to, first and foremost, to make sure that we recruited HIV diagnostic assistants or counselors who were certified by the Ministry of Health. So that one was one key step that we did to ensure quality of services provided. Now, the next thing, of course, is we have a number of supervisors, starting from the national and the district level, HTS supervisors and laboratory supervisors that provide support to the range of counselors and HIV diagnostic assistants working in the different facilities. So those also are also another level of start to ensure quality services are provided. There is proficiency testing among all the providers. We have also direct observation during service provision for providers, especially by the supervisors, just to ensure that they are following up all the required steps. And we also had a dedicated number of mentors who are also oriented on HTS quality standards, who are also supporting the counselors and the HIV diagnostic assistants in service provision. So I think all those are key steps that we follow to ensure the quality of the services being provided in the facilities. Thank you.
Thank you, Aziz. That sounds quite a comprehensive approach. Arturo or Tiago, do you want to talk about ensuring quality in the community-based testing?
Yes. You hear me?
Yes.
Okay. Really, in Angola, we have a great experience because, you know, always when you work in the health facility, concentrate all the activities over there is something happened, no? It's necessary to go to the community because all the diseases born in the community. So for us, was really a great experience when, in our case, to contact all the community counselor, that is the main person working in this case, when go to the community and try with this person, with the approval of this person, to go to the relatives, to the children, to the other person, and confident, without discrimination, in a personal and individual contact, is totally different than with this person come to the health facility to do a test, because this person has to lose a lot of time, just maybe all the morning, talking with one person, to all the things that HIV is. Not only, talking directly to do the test or not to do the test. It's just entering confidence with this person. It's a great experience that, and the main two results is that with this strategy that we started a long time here in Angola, now the results are extraordinary, because the number of positivity that we find is sometimes 3 times that we found in the health facility. And beside that, the more successful thing is the linkage to the treatment, because this approach, individual approach, means that all the person that are positive immediately go to start the treatment in the health facility. So our linkage to the health treatment, to the TARP, is a main problem here in Angola. And now with this strategy, we try to find, and we discover that we achieve almost 80 to 90% of the person HIV positive linkage to the treatment. So it's a great experience, and besides that, we have a lot of stories, beautiful stories with the person, because most of the time this person work very slowly, very confident, and save lives. That is very important, this sign of humanism in this strategy. Thank you.
Great. Thank you so much for that explanation. And you talked about the linkage to treatment, so I actually have a question here from Andrew in Nigeria about the Ethiopia experience with the linkage rate of 95% that was reported. So that's a great linkage rate. And could you tell us a little bit more about the strategies that were deployed to achieve this linkage, especially within the community? And were there any incentives that were helping with this?
Thank you again. Since Dr. Bayo, the Chief of Party, is with me, he will address that question. Hello there?
Yes, please go ahead.
Good. Thank you for the question. So our index case testing approach is part of our comprehensive care and support service package. So we are not going to households or approaching the index cases for the sake of testing. But what we are doing is we are trying to approach the index cases to provide them HIV care and support activities. As part of that package, we'll also offer index case testing for eligible partners and also family members. So that has helped us to improve linkage. So it will help you to build a rapport, a friendship with the families when you are attending the index cases. So when you are offering the test for eligible clients for index case testing, it's relatively easier than just going for index case testing. That has helped us a lot. And then we also, scored the cases who are turned out to be positive. So we have what we call community resource persons, which are volunteers. These volunteers are paid HIVs themselves. So they give the counseling and they do the necessary preparatory work for the testing. Once they are converted to be positive, they will also escort them for linkage. And the other thing is that for programmatic purpose, we have what we call a positive tracking tool. So that positive tracking tool, once a person is identified to be positive, will track what happened to that person. So for example, one of the challenges we are facing is to link them on the same day to the ART centers. But we have that the tracking tool to make a further follow-up, and we'll make sure that that person is linked later on. And this also helps us to be an auditable referral linkage, because the moment they are linked to ART services, we'll document the ART number, the unique identifier, to that tracking tool, so that anyone who wants to verify whether that person is truly linked or not, we can link to that number as well. So this is also one thing that we have also observed. And by the design of the project, what we have made is we have used the PLHIV networks, associations in the heart of the project. So these associations, they have case managers in the health facilities. They have also volunteers or community resource persons in the community. So there is already a health facility and community linkage. So that's why we are building our hub and spoke model that Asayeng was describing during his presentation. So that design by itself helps an easy communication, between different actors because they are working with the same PLHIV networks. So that is really one added value to improve our linkage. Going forward, since when the number of claims are increasing and the data volume is also increasing, one threat is we cannot continue documenting all this on paper-based. Now we are working on digitizing this on what we call a ComCare application. So we are now in the process of developing that digitization with the Ministry of Health so that the ComCare application will also help us to be digitized and it will have more other functions as a case management tool. So these are some of the approach we are trying to implement to ensure a better linkage. Thank you.
Thank you so much for that explanation. That was really helpful to hear what the comprehensive package is and then what you're doing next to help facilitate programming. The next question I have will be for the team in Angola, for Tiago and Arturo. Can you please tell us a little bit more about what explains the high positivity rate in the pediatric hospital? Who were the indexes and contacts? And also, at what point did you establish eligibility of the contacts for testing?
You hear me?
Yes, we do.
Okay. First of all, that we have very high linkage to treatment almost in all the health facilities, different like the normal patient in the health facility, within this case, of course. So in the pediatric, because all the in the pediatric ward in the big hospital pediatric of the reference here in Rwanda, we have to test it all the children that came to the hospital, and after all these patients initially the treatment over there. So we can say all the children, as soon as arrive there with the parents, we testing all the children plus the testing the father. And sometimes all these children is testing because the father some consulting, and we take this opportunity to take the children as well, and all the positive start the same day, because we have one strategy here is to test and treat. It's a national strategy by the Minister of Health, so the same day we can start the treatment. Of course, some children less than 18 months, in some cases we have to wait, or to do the early infant diagnosis to provide the HIV positive. And in this case, we start the treatment immediately, and the parents are referred to another health facility that is very close to the hospital to follow the treatment from the parents. So this is a very nice strategy. When some children came there for another pathology, maybe we convince to the parent to do the test, and if they are positive, immediately we test the children and we start with the treatment. So positive are a lot, and link us to the treatment as well. Thank you.
Great, thank you very much. The next question is for our colleagues in Malawi, for Aziz and Rose. One of the biggest challenges with index case testing is the distance to the health facilities, especially in the Malawi context. Can you tell us about what measures you put in place to ensure that the index contacts were able to come in for testing?
Well, I know distance can be a major challenge in Malawi, but for this particular project, we did not have any particular incentive to ensure that contacts of index clients are able to come to the facility. But I think from our implementation, what we realized is that index case testing was still a choice that was very liked by quite a number of our clients, and most importantly because we had what we call family testing days established on a weekend, mostly on a Saturday, that runs half a day, and clients actually preferred coming for this service because it was basically dedicated to the index clients and their family members, which means the services were much more centered. You know, unlike when you come to a facility on a very busy day when the health workers are also dealing with all sorts of cases in a facility, then you have to wait for too long. So this, I think, was very popular among our clients because they realized that the waiting times were actually very short, and they actually get a very personalized service from the HIV counselors that were deployed in these facilities. So even though distance can be a challenge, but because there was also a special kind of service being offered in the facility that the clients liked, we didn't actually notice that the distance was actually affecting our project implementation. Thank you.
Okay, thank you. And we have a short follow-up question. What proportion of contacts that were issued the FRS sheets returned to a facility for testing?
Well, we issued quite a number of FRS. Of course, as from the presentation by the director, you see all clients who identified either as positive or even those who were negative were given FRS. However, we were not able to track how many of the FRSs that were issued actually returned back to the same facility, because sometimes you can issue an FRS and a client goes to a different facility. So it wasn't very easy to establish the exact number of FRS that came back to each of the facilities. Now, in order to do this, of course, it requires introducing a number of other tools to track this. And what we were not very interested in doing was to introduce other tools, but actually preferred to use just the standard MOH tools that were existing in our facilities. But of course, I know this was one of the drawbacks during the implementation, that there were quite a number of things that we needed to track, but we were not able to track because we just decided we needed to follow the MOH tools that were existing and not introduce anything else. So, yeah, thanks.
Okay, thank you very much for that additional detail. So thank you to everyone that is submitting questions. We're getting quite a number of good questions. And we have one from Joseph from the DRC. In any of the 3 countries that we're talking about, have you experienced cases of stigma in the community, or have you had cases of poor HIV management that came about in this community-based approach? Maybe I'll start with Ethiopia.
Okay, thank you. I mean, as the program is new and we haven't actually looked at the cases of actually stigma and discrimination that were encountered at service delivery level. What we can say here is that we've witnessed some areas where provision of services, particularly testing services for index cases, families and sexual contacts, were not up to the standard in relation to particularly addressing the infection prevention and personal safety measures. As the program is new and some of the supplies were not in place, what we saw during our support supervision visits and quality assessments at site level were related to infection prevention, and we have started addressing those through central procurement of personal safety and infection prevention supplies to partners, because some of the challenges were related to those, and the others were related to health worker attitudes, and we have tried to address those through trainings and providing UNAIDS. We are hoping that these things will improve in the future. Thank you.
Great, thank you. And Malawi, do you have anything to add?
No, for Malawi, our project was very much facility-based, and I think from all the 90 facilities, we never experienced any case of mismanagement.
Mm-hmm. Okay,
Yeah.
Thank you. And Tiago and Arturo in Angola?
Yes, I have to say that in Angola the stigma is very big. Continue to see the stigma very big here in Angola, but I think that improving little by little is improving, especially because all the community counselors are well prepared, and with the supervision that our staff doing every day in the care facility to this person, training on this stigma and on discrimination especially. And they have a good training, they have a good preparation now, and overall they have a good experience to working against the stigma. So when they arrive to the community, they don't know, most of the people don't identify with the voluntary or community counselor of HIV, because they come in and start working first in prevention of malaria, on prevention of yellow fever, on prevention on hygiene, on prevention of vaccine, and in between them, among them, they start to talking about the HIV. Of course, that is the central issue for the community counselor. But when you came to the house with training already done in the health facility, and you know the stigma, you are well prepared to share with the person another thing or against the stigma that is very big in Angola. And I think that we have a very good result, because they talking a lot of diseases in the house, and besides that, the personal interview with the person and talking about another thing of the life, share with them this part of the life, I think that improves a lot the stigma. And after that, when this person have to come to the health facility as well, we have this path. That is the personnel that working for us in the health facility that continue with the follow to the patient with a right there, and follow all the services of this or that. They feel so confident, the patient with a right as well at the health facility. All of this is how to fight against the discrimination, against the stigma that is still in Angola. But the good news is that day by day, I saw that little by little, we can improve the stigma. Thank you.
Thank you very much. So a number of people have asked questions about gender-based violence and intimate partner violence. So a question for any of you. When doing index case testing, were any cases of intimate partner violence reported? And could index case testing and home visits in community testing be used as a way to identify gender-based or intimate partner violence in the future? So I will start with the Malawi team, with Aziz.
Well, in our case, we never experienced any case of gender-based violence. I guess, the approach we used was a passive approach, where we ask the index client to literally invite their partner or sexual partners or spouse through the family referral slip to come to a facility for testing. And I think through that approach, in all the 90 facilities where we did this, we never had any case of gender-based violence reported.
Okay, and just wondering, would that be a venue for identifying that type of violence?
Well, I guess maybe, I guess as we move towards more, start piloting more active partner notification approaches, then maybe that's a way through which we can actually get to determine if there are any cases of gender-based violence. But from the approach we used, which was passive, no, there was none reported.
Okay, thank you. And what about from Ethiopia? Asayahin, has this come up as something potential or anything that you've experienced so far?
Yeah, we have anticipated these issues, yet the partner notification services have just been approved by the Ministry of Health recently, and we are going to initiate those, taking into consideration the possibility of intimate partner violence, reducing it, and trying to address them as they happen. We also have, a strong component of gender-based violence response, integrated into our service delivery. Apart from that, we haven't yet witnessed anything, except that majority of our index clients are women, which might tell you, acceptability of testing and the fact that these things could be very much prevalent. So we need to do assessments and institute these interventions once they come up. Otherwise, we haven't observed anything.
Okay, thank you. And what about from the Angola example, Tiago or Arturo? Has this been an issue that you've encountered?
Yes, I have to say that we didn't receive any report of violence in the community. At the contrary, sometimes because, I think that it's because this individual and personal interview inside the house and so on. But sometimes the neighbors know about this prevention in all these disease and so on and so on. So sometimes requesting that this person go to her house or to their house to visit them and to receive this information. So I think that is a good news. Until now, we didn't receive any report, any violence reported to us. Thank you.
All right, thank you very much. But yes, this clearly is something that people are aware of and we can monitor going forward in our programming. So as I mentioned, we've been getting a lot of questions, but we are coming to the end of our time. I think we have time for maybe one last question for all of the panelists. The examples that were described today require some investment of resources for teams of staff to implement, either at the community level or in the facility level. In light of potential decreases in donor funding in many countries, have you found these approaches to be cost-effective? I guess I will start with Malawi.
Well, I don't have the exact dollar amount, but I know that quite some studies have gone into the cost effectiveness of the approaches that we're using. And one of the things I know that index case testing compared to some of the approaches that have been implemented was seen to be very cost effective. And it's something that I think even with reduced donor funding, it can actually still be supported by the Ministry of Health. In fact, if you look at the Ministry of Health guidelines, index case testing is one of the approaches that have been proposed. And of course, based on the implementation we had in the different facilities, you can see that most of the health centers, for example, where we have the family testing days on a weekend, those health centers are still open actually on a weekend half day. So they can actually still continue to provide those services without really incurring additional costs. Similarly, index case testing offered during a weekday at a facility. When a facility is open, there will always be the health workers who provide the services in those facilities. And so I think based on the cost studies that have been done in Malawi, we found that index case testing was very cost effective and can still be supported by the Ministry of Health moving forward. Now, I think just one major piece that was still pending was the case of HIV diagnostic systems that by and large have been supported through donor funding, but there are plans by the Ministry of Health to absorb this cadre of staff into the structure. And I think if that is done, then we'll still have a dedicated cadre to provide HIV testing services in the facilities. I think that's the one piece that the Ministry of Health will still have to work on. But by and large, I think the strategy we use is very cost effective.
Great, thank you very much. And we're quickly running out of time. Ethiopia team, do you have any comments, quick comments on the cost effectiveness of this versus other approaches?
Yeah, overall, as we have presented earlier, this index testing at community level is being implemented as part of our community-based care and support activities to also address the second and the third line at community level. So overall, we don't have as such huge investments to implement index testing, but thus far, majority of the service providers, whether health workers or the community resource personnel volunteers, they also are tasked to deliver other care and support services. So we are not, we don't have those cost effectiveness analysis done, and we don't have the figures, but what we see is like, in an integrated manner, we are delivering results. And the caseload, the numbers that we are reaching and the new positives that we are identifying seem to be very much comparable, if not better, than facility-based services. Thank you.
Great, thank you so much. And Arturo and Tiago, any quick last thoughts on this?
Okay, in our case, it's the same experience that Ethiopia and Malawi, because this strategy is very cost effective. So comparing with another strategy, I think that everybody here or the partner want that we can expand. If we can expand this strategy to another health facility. So I think that is very cost effective in case that we have to reduce, we have to prioritize this strategy because the result that we find is totally very cost effective strategy. Thank you.
Great. Thank you so much. There's clearly quite a lot of interest in this subject, and so I really appreciate all of the panelists for presenting and discussing today, and also to all the participants, especially those who submitted questions. We hope that the presentations and discussions were an opportunity for you to learn more about index case testing and its potential to help reach the global 90-90-90 goals, and especially among groups that we've historically not been effectively reaching. If we weren't able to get to your question today, we'll be reaching out to you directly to share additional information or to connect you to the appropriate country team. So again, thank you all for participating and have a wonderful rest of your day.